Good morning, everyone, and thank you for joining us today. My name is Melissa Miranda, and I'm the QIN-QIO Regional Lead for the Collaborative, and I'll be moderating today's session. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded, and the presentation is available on our website, www.healthcarefornewengland.org. The phone lines will be on mute for the duration of the presentation, and we ask that you please do not put your line on hold during the webinar. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. I'm joined by my colleagues from each state's QIN-QIO team who will be monitoring and responding to you through chat. There will be time at the end of the presentation to ask questions as well. Also, if you find that your presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust accordingly. During today's session, we will continue our focus on transitions of care. Our goal is simple, that New England nursing centers will apply strategies and best practices that will aid in reducing hospital readmissions by 20% or more over the next 5 years. The intended outcomes of this virtual learning series is to, 1, make lives care by ensuring that your staff has a vast working knowledge of transitions so they know what to do, and that they have a sense of confidence that they're doing the right thing. For anyone who's speaking today, could you just place your phone on mute? Thank you. This learning series is actually a virtual library of information and education about care transitions and various topics that directly impact transitions, and it's intended to be a resource for you in educating and supporting your staff. Our goal is that we hope that as a community we become adept at care transitions. The objectives for today's session are to continue focusing on QAPI supports and how that helps your improvement, to learn how other nursing centers are implementing the education and strategies so far, which is something that we will incorporate more and more throughout the collaborative, to learn why effective tools to prevent and manage adverse events can reduce hospitalizations, and last, to learn how end-of-life care also impacts care transitions. Let me briefly recap where we left off and then introduce our faculty for today. Between now and right now, we've asked participants to access the QAPI module on our website, and in doing so, you would have identified a quality team, developed a QAPI charter, and hopefully identified a problem, maybe even conducted a root cause analysis, and hopefully, possibly even began to complete a PDSA cycle. All of this work is part of developing a PIP. We've also asked that you review Learning Module 1, which is an introduction to care transitions. It's a good idea to develop a plan on how to use this education with your staff. Like I said, these modules are becoming a virtual library of education at your fingertips. It's a buffet of information that you can use with your staff when you need it. All of the topics that we're covering in Learning Series 1 can impact care transitions. So let's move on to today's program. I'd like to introduce a segment called Share from the Chair. Today, Kimberly Ciciola and Anne Cabral from the Silver Creek Manor in Bristol will talk briefly about some of the quality improvement work they're doing and how they've been using their participation in this collaborative to support their existing efforts. Hi, Kim and Anne. Kim or Anne, if you're on mute, you have to unmute your line. Nancy, are you on? Is there any way to access The unmute button.
Kim and Ann, try pressing *6 on your phone. Kim or Ann, are you there?
Okay, I think we're going to just move on. And if they join us, Nancy, we'll go back to this segment.
Sounds good.
Okay. Okay. Diane, are you available? Are you there?
Yes, I am. Can you hear me?
Okay, great. Let me just do a quick intro for you. Sorry about that. Okay, I'm happy to introduce you all to our first faculty speaker, Diane Vaughn. Diane is a nurse and licensed administrator with over 37 years of experience. She's also the Senior Vice President of Clinical Services for the Benedictine Health System, which is a large multi-state healthcare system. Diane's the chairperson of Office Clinical Practice Committee. And today she's going to highlight information from the learning module, Effective Tools to Prevent and Manage Adverse Events. Diane?
Thank you. The first thing I want to say is events happen, and we know they happen, and we certainly want them to happen less. They happen so much that the Office of Inspector General, as you most probably know, in February of 2014, developed the 69-page report on adverse events in skilled nursing facilities. What we did is we've created Module 2, Lessons 1 to 3, to help you dissect that report and understand what are the events that are happening in our care centers, and then provide you some strategies that may help you reduce your risk for adverse events from happening. Next slide, please. Lesson 1 is an overview of the adverse events report. The OIG Adverse Events Study was completed through retrospective chart reviews by physicians, and they studied 653 Medicare beneficiaries who transitioned from the hospital to a SNF. These patients had a length of stay of less than 35 days. Of this sample, nearly a quarter of them, 22%, experienced an adverse event. An additional 11% experienced a temporary harm event. So in total, 33% of the Medicare beneficiaries experienced a negative outcome during their short stay. The alarming part is the physician reviewers noted that 59% of these adverse events were considered preventable. And the cost, which drew the attention of the government, of the 33% when annualized, came out to $2.8 billion. The report identified that better recognition of the adverse event problem is essential. Improved documentation is needed, noting identification and management of adverse events, and increased accountability for prevention is essential. The two words that stayed with me as a provider is increased accountability. To me, that means there's going to be a higher focus than ever on adverse events, perhaps even through our annual surveys and complaint investigations. And adverse events, just by their definition, would probably end up being a scope and severity of G or higher in our annual survey process. But do not despair, and I'm trying to get this word out to everybody, that there's a statement in the report that notes referring to adverse events. It states, however, adverse events do not always involve errors, negligence, or poor quality of care and are not always preventable. This is a statement I want to frame personally and keep on the wall in the room where the surveyor's team works out of to remind them that also. So to better understand adverse events, the OIG broke the outcomes into three major areas of adverse and temporary harm events. Medication-related events was 37% of the adverse events they found and 43% of the temporary harm. Care-related adverse events were 37% of them, and of temporary harm events, the care-related events was 40%. And infection-related adverse events was 26%, and of temporary harm events for infection, it was 17%. The report also talks about when adverse events occur, noting risk factors for adverse events. Friday afternoons, to no surprise of anyone, Friday afternoon admissions especially, and when there is no planned transitions of care in place, takes you even into a higher risk. This module will take us deeper into what the report calls preventability rationales. What it did is it found 6 major areas that cause adverse events. So what that does for us is it helps us break it down and take it brick by brick and fixing any areas that we might have at a high risk. Also in this module, we talk about the term cascade event, the term omission and commissions of care, and we talk about the MERP scale for determining the level of harm if we're trying to assess ourselves and see how would we rate with our adverse events. And then it offers an outline to strategies to identify and manage adverse events. Next slide, please. Module 2, Lesson 2 provides a brief overview and then goes deeper into those 3 key areas of medication care and infection, offering many interventions that may help lower the risk at your care center. This module shares resources and web links also that can assist the SNF in developing a culture of safety and quality. Most importantly, this lesson shares proactive processes that will help your care center in reducing the prevalence of adverse events and or identifying them as early as possible. Topics such as admission criteria and capacity, identification of early warning signs, assessing harm, and root cause analysis will be discussed. It then proceeds to share examples of infection-related events, the medication, and care events at a deeper level, to give you some specifics. Infection, although fewer in percentage than medication or care-related adverse events, actually caused more rehospitalizations. We will share the Health and Human Service National Action Plan to prevent healthcare-acquired infections for long-term care as one of the resources available. Medication-related events can range from anticholinergic effects, use of ACE inhibitors, insulin use, loop diuretics, and if you track emergency room visits as you're also tracking rehospitalizations, you may have found that electrolyte imbalance seems to be up in the top 5 or at least the top 10 of reasons to go, and often it's because of these medications. It discusses the importance of engagement of your pharmacy consultant and medical directors in medication management and oversight. Care-related events noted inadequate monitoring, from labs being missed or followed as they should be to delayed responses of care or not recognizing key warning signs. Next slide, please. Lesson 3 focuses on really trying to avert those rehospitalizations by managing and reducing that risk of adverse events. And it has very practical ideas to assist with improving staff capacity, documentation, and management of adverse events. Transitions are dangerous times. The handoff of care from one level of care or provider to another is very challenging if it's not planned. This lesson outlines how to reduce rehospitalization rates through transition management. These care centers aggregately that we talk about in the presentation reduced rehospitalizations from hospital to SNF by over 40% and SNF to community by 32%. The lesson then goes into critical thinking. We often hear that criticism of our nurses. Our nurses are not critical thinkers. And how do we raise that capacity of our care center to take on more acuity? And some of that is through ideas such as simulation and care drills. Care drills allow for practice of events that are likely to occur on your unit. The staff can practice and even fail without harm to a patient. Then they can master the skill and or critical thinking components needed for the types of patients you have, and when real events occur, perform with excellence. Interact and QAPI are also discussed. Part of what the OIG found was that in some cases they could not determine if an adverse event was avoidable or unavoidable related to poor documentation or missing documentation of the events. This lesson covers a very important process I call proving unavoidability in your documentation, and also a tool I've named Tell the Story Interdisciplinary Team Notes. It includes explanation of these terms and a template that can guide your staff and your interdisciplinary team in clarifying a messy situation or an ever-changing resident condition, so you can really show the work that you have been doing that doesn't always get into the chart. The Office of Inspector General report is going to have a big effect on us, but ultimately it is going to help us if we use it as a tool to improve our quality and reduce our risks. I'm hoping that you can all join us for all three of the modules. Thank you.
Thank you so much, Diane. I just wanted to do a check-in to see if the folks from Silver Creek are on. Anne, are you on the call?
Yes, I am.
Okay, great. So Diane, thank you for presenting on your learning module, and just so everyone knows, that learning module is up on our website today. I'm going to backtrack a little bit just to go back to Anne's presentation, and thank you, Anne. I'm sorry that you ran into a little difficulty there, but I'm very happy that you're able to join us. So this is a segment, like I said earlier, that we're calling Share from the Chair, in which we're hoping to get some of our nursing center participants to come on the call and share a little bit with us. And Kim Ceciola, who's the administrator at Silver Creek, and Anne Cabral, who's the QAPI director, reached out, and they've been doing some really great work in QI. So I'm going to turn it over to you for the next few minutes, Anne.
Thank you. Thank you very much for having me, and hopefully we'll be able to share some information. Obviously, the whole process is a little new for some, and as well as us, so we're just going to give some ideas and things that we've been working on, so hopefully it'll be a benefit to people. One of the things that we wanted to hopefully demonstrate was how we worked QAPI into our center. My title is actually QAPI Director. I was fortunate that a whole position was created around that, so that's really been a benefit for us as far as getting everything off the ground and giving dedicated time to that as well. So we're in a fortunate position with that in that regard as well. I'd like to provide some ideas for spreading information regarding quality, provide some examples of how to build a team and how we've been able to build multiple teams in the past couple of years. Some of the presentations I can tell you about that we've done for the staff, and other ways to share the data and all the information that a few of us get in the webinars, and how we give it out to all the rest of the building, and deciding ways to get that input back from the staff and who we use to do that, and how if it's been successful or what our challenges have been. So the first thing we did a couple of years ago was actually do the QAPI questionnaire when it became available online, and going through and seeing where we were at as a center, as a facility, if we were ready to begin. And obviously the answer was a resounding yes. There were a lot of areas that we wanted to look at, but we also seemed to have a lot of the things that would be necessary to get some stuff done. So we went ahead with creating a couple of presentations for the department heads, specifically because I wanted to get their buy-in and get them on board and having them really understand what the process was, that it just wasn't QA. Some people were familiar with PI. I came from the world of TQM, CQI, and I'm sure all of us have had multiple abbreviations that we've had in those positions. So I really wanted them to understand how the merger of QA and PI was really beneficial to the center. So we created those presentations and held them and asked questions, answered their questions, and really got their support. I also explained the process to them about choosing projects and how we were looking to them to be the leaders, but also to build their own teams regarding their projects. They also chose their teams, and then they report monthly to our QAPI meeting as well. What we really wanted to do was make QAPI a habit, and as we all know, habits, good and bad, involve a cue, a routine, and a reward. So I really wanted to create the environment here with our staff that anytime we see a process, so it could be an improvement or anything that comes up in conversation, really, to say, is that something that needs to go to QAPI? And that's been kind of the coin phrase that we use here. They actually say, is that a QAPI thing? And, so they get it. But we really wanted to get them to that point to recognize what is a possibility, to make it part of their vocabulary, and then what do they get when they put those teams together? What kind of reward is it? So we do storyboards and a few other things that I'll talk about in a few slides. We look at the process and we talk about how we can make things go more smoothly and more efficiently. Those are some of the cues that we give the staff when we ask them and when they come to us with ideas. They're not all the based on data or bad reports, bad outcomes, anything negative. They've actually, some of them are just based on the staff's desire to make things better. Some things are just fine, but the benefit that I'm proud of here that we worked hard is to have them not just be okay with fine. We want better than fine for our residents, and they want a better than fine place to work. So both of those things combined have kind of helped us with that process. So in order to have the department heads lead off, and this was in the very beginning, so this is going back to the beginning of 2014, I really wanted to have a leadership person, a department head, to start the teams and inevitably take that from them and encourage other staff to be leading teams, and that's where we're at today. But it did start with department heads initially. We did have to set some parameters because the tendency was to just all work as department heads and not bring anybody else into the equation. So we had some kind of rules, little parameters to go by. They could have no more than 2 department heads, and they had to have at least 3 departments on their team, and it had to be at least 7 people. And we also wanted them to have different shifts or people that worked only weekends from different departments as well, just to give them a good picture and really get people that it affected or had maybe even had more input than they did on the topic. I would meet with the team leaders and fill out a QAPI plan form and talk them through the 5 whys, and they may come in with big, huge goals, and so I would try to get them down to something smaller just to see if that would lead to perhaps, rectifying that situation. So we tried to make things a little easier by making them a little smaller. Then that team leader or team leaders would present it at the QAPI meeting, outlining how long they thought it might take, who they had on their team. Some of the team leaders were very formal, very creative with their invitations. They actually made formal invitations and presented them to different staff people. The staff thought that was great. They also thought it was okay when people just kind of pulled them aside and said, hey, I really think you could share and add to our team. Would you like to be a part of it? So we had department heads that really went all out with decorative invitations on the computer, and others that just had really good relationships and said, hey, do you think you want to work with me on the team? So they took it either way for them. This TIP team they had to meet at least twice before the QI meeting so that they could get some ideas together. And then either the leader or any member of their team could come to our big QAPI meeting and present what they were doing. If they had any data. I also created just like a report form that they would tell me where they were at. Who was still on their meeting, how many meetings that they had. They didn't have to keep formal minutes, but they all did anyway in a notebook form. And they would just report on where they were at, if they needed more help, if they had questions. But it was their time during our QA meeting. At the end of it, or during it, they were also taught how to do the root cause analysis. They were all taught how to do fishbones. And I also taught them different methods of data collection. Depending what they were looking at. So they used as many tools as they could to get the data that they needed. We also used the things that we already had at our disposal, but they did have to create a few different things to get some of their information, different log sheets, etc. At the end of the whole project, when they had completed it, after having it presented at QAPI a few months, they gave me all their information, and then I used a Plan, Do, Study, Act template to create storyboards. And to date, we've completed 6 projects. We'll have 6 storyboards, and they're done large, poster board size, film clipboard, displayed for people to see. We take them down, and we're due actually to put a couple of new ones back up with the new information. And they get a lot of pride out of that, seeing that they were part of changing location of something or changing a process, for the betterment of the residents. In the course of that, we also educated about person-centered care. So one of the things that came up, and we did do it as a QAPI project, had to do with person-centered care and we took the recreation point of view and the leisure activities point of view. So we looked at the demographics of the residents that we have in-house, looked at what stage of the dementia disease, whichever one it was, if we could, to see if they were early, middle, or late. And we documented that and looked at how involved they were in activities and participation. We then put in place a cluster program that used environmental stimulation, so in other words, how they did in certain situations, how much time frame their attention span was, what they did, what kind of props did they do well with, etc. And then we built a Montessori design program around that base. The Montessori program protocol that I'm using is the same as in education. So the residents who have dementia sit with people at the like functional level that they're at, what they're able to do, and but they're still doing the same thing. So in other words, if it's flowers, we may have 3 tables set up with people that have more of an early stage dementia, then a middle stage dementia, and a late stage dementia, and they're just doing something that has to do with that theme, but according to what they'll be successful at, because obviously we're pushing for the person-centered but also failure-free. All the staff have been in service on that. We've done a pilot now for a few months, 1 time a week on both of our floors, involving over 20 residents with the setup that I've described. We also designed a sensory program using Montessori again with a theme approach, and this focusing, however, on late-stage dementia in this case, and the director runs that program. It's all 5 senses, and it is based on a theme. Both of those are going to increase to 2 times weekly because we have noticed that there has been an increase in how long they're in the activity, how engaged they are. We know we've done a lot of education combined with programming, a really good relationship with our psych service, our pharmacy, and our medical director, and buy-in from everyone in the facility. We'd be able to lower our antipsychotic rate, and we're really working hard at getting it down as much as we can to benefit the residents again. We would like to have, and we figured out that it'll be about 40% of everyone with dementia on both floors will be engaged in 2 specialized programs per week on each floor. To that end, our CNAs were very involved in that education process. They have to participate in it. We actually did sample groups with them so that they could understand what we were talking about, and it was very successful. But they asked for more information about the residents, and knowing that as social workers and our activities people do the interviews, they get all that great information about the person's past, and we were struggling with a way to get that information to the CNAs and the rest of the staff that were asking for it. So we're creating a profile book, a resident profile book, that eventually, because we are all electronic medical record, we're trying to think of a way to get that onto their point of care kiosk in the hallway so that they'll read it. They'll read about the people before they go take care of the people. And then they could also use it for diversion, conversation, etc. So we are working on that, but the book is actually being done by 3 different departments, and we're trying to get as much information per resident. The resident's part of it, obviously, in the family, but some of our CNAs have great knowledge of these people as well, so we're trying to bring them into that project as well. And again, that was a result of a QAPI process. Education, obviously, is the key. We have 70% of our staff has received 8 hours of dementia training, as well as 4 hours of behavior management training here. It's not yet in Rhode Island, but we hope, we know that we're well on our way to getting our staff equipped to do the best we can with people that have dementia or any disease, really. We're a host facility for the Certified Dementia Practitioner course. I am certified to train that class. We just held our first class for the area, and we are preparing to have 4 of our staff put in their applications, and they will be all certified as CDPs, or Certified Dementia Practitioners. So we're looking forward to doubling that in the fall, and then again every season try to add 4 to 5 more people to our list of people who have received extra training and are certified now in dementia. Our small equality team, which we made up of 10 people for this New England Coalition specifically, It's made up of all different staff, all different departments. They've worked really hard. They've done a lot of just group work. They've come up with definitions of quality that we've put on 10 cards and left in the break room and left around for people to read and telling them where it came from. To do that, they actually had to solicit from their peers as well what they defined as quality. They came up with characteristics of an exceptional Silver Creek Manor worker, and we put those out as well. And again, they had to go out and ask their peers as well. And they just completed a SWOT analysis as well about Silver Creek Manor. And we're taught how to do that, and they really have a lot of fun with that. Some of the members attend these webinars, and then we design a PowerPoint to educate the rest of the team and then the rest of the facility. Each meeting results in them getting some type of assignment to go out and spread the word using that pollination education approach is what we really bought into. We did have an occasion with person-centered care, a resident who is now 111, last year at 110, had a reunion with her two sisters who were over 100. It was published in People. It was covered by the media. But the real impressive part, other than the family themselves, is also the staff buy-in. They were so excited to help get her ready. They were so proud to bring her down to the reunion. Some of them had worked with her for years, however, hadn't met a lot of the family. So they learned a lot more about the person they took care of, saw old pictures, heard old stories, and it was person-centered at its best. They were really, really proud to be a part of it, and the family really appreciated their efforts. As far as transitions and Interact, they've actually been doing SBAR here since 2012. It's been electronic as well. Our plan is to really look at a teaching schedule to get all our staff educated using the transition modules as well, so we'll be beginning that in a couple of weeks. They have been doing SBAR, as I said, for quite a while. They're very familiar with the process. We know that the goal of Interact is to improve the early identification, evaluation, management of the issue, documentation to support the process, and then communication to who needs it about those changes. They also use a change of condition report. They had a binder that was created by the Assistant Director of Nursing that outlines all the care paths, so there's never a question. They know right where it is, they know where to go, and they just follow it right through. The staff has been educated regarding trumpet care interventions, and again, where to locate that in the binder, as well as hospice palliative care and where to get more information if they would need it. The Staff and Watch, I've used it in different environments prior to coming here, and they've used it here as well in paper form. And we're looking at, they're not using it currently. However, we are looking at trying to make it electronic rather than paper to go along with everything else that we're doing, and really still getting that input and valuable assessment or, at least observations from the rest of the staff and forwarding it over to nursing. The outcomes of Interact, as we know, are to improve communication, improve the assessment, the documentation, reduce rehospitalization rates, improve the QI process, and obviously we want to better our hospital relationships. Ironically, or not so ironically, the goals are the same for us for transitions. We want to do all those things, but we also want to improve their transition to the new location, wherever it would be, whether it's in the same hallway, on a different floor, out of the building to home, to another hospital, to another nursing home, assisted living, wherever they would be going. As far as what we have planned for the future, we're working on developing a short-term recreation program that would involve getting the community involved when they go back home. We would like to finalize that person-centered profile to electronic version, so we don't have a book of papers with it. We also want to finalize an electronic version of the Stop and Watch so that we continue to get the input from the staff, but also, have it be a little bit more efficient. We would like to complete the transitions models. We would like to develop a PIP and a team to look only at rehospitalization. Right now we look at it through QAPI, but we also look at it through the Advancing Excellence. So we're looking at that we need a separate team to look at that as well. And we also are looking to develop goals for transitions and a QAPI plan to measure that success. And we are going to stick with the Plan Do Study Act because the staff's familiar with that and it's been successful for them. And that's all I have.
Great. Thank you, Anne. That was a really great presentation, and it's quality improvement in action at its finest. So I really appreciate you taking the time to share with us today. For everyone on the call, or on the webinar, actually, if you have questions, please don't hesitate to put them in the chat function or hold them to the end of the presentation. Thank you. So now we're going to move on. We're going to move ahead here to our next presenter. Now I'd like to address our next topic that impacts care transitions. I'm happy to introduce Sarah Dereniuk. Sarah oversees the Nursing Home Quality Care Collaborative in Massachusetts, and her background is a nursing home administrator, and today she's going to introduce how end-of-life care can impact your care transitions. Sarah?
Thanks, Melissa. Knowing the important role that end-of-life care has for your patients, their families, and your staff, we wanted to bring in some experts to help us build a learning module for you. So we turned to Good Shepherd Community Care. Good Shepherd Community Care is one of the most trusted healthcare organizations in Greater Boston, focusing on hospice and palliative care. Founded as a hospice of the Good Shepherd in 1978, it is the original Massachusetts hospice. After decades of caring for the community, Good Shepherd continues to remain an independent, nonprofit, non-sectarian organization. As part of their mission, Good Shepherd is committed to providing education about dying, death and bereavement, and hospice philosophy and care. The Good Shepherd Institute's research and educational programs reflect their mission towards enhancing the quality of remaining life, so that those in the final stage of life can live as fully, independently, and as comfortably as possible. Before turning this over to Good Shepherd, we would like to hear from you all. It is really important for us to know where you are starting in your end-of-life care quality improvement journey. So we have put together a polling question. Next slide. Does your nursing center currently have a mission statement specific for end-of-life care? Yes, no, or not sure? Please start the polling question. We'll pause for a moment to have a chance to get those poll results in on the screen. While we pause, make use of our chat function, and please feel free to tell us in chat one area of end-of-life care you want to be sure we explore in our online learning module. Before we review the polling results, it is my pleasure today to introduce to you Jennifer Sachs from Good Shepherd Community Care. Next slide, please. Jennifer is a dedicated human services and public health professional with over 13 years of experience. As the Director of Communications and a community educator for Good Shepherd, Jennifer has written and spoken extensively to raise awareness about the importance of having conversations before the crisis and the importance of end-of-life planning. She's a strong advocate for improving patient choice about end-of-life care options and the benefits of hospice care. Jennifer?
Thank you, Sarah. Can you hear me, everyone? So I'm just looking at your polling results, and it's nice to see that some of you said you do already have a mission statement specific about end-of-life care. You're off to a great start, and this end-of-life care module that we're developing will be able to assist you in developing these values even further. Some of you said no, some of you said not sure, and there was a good portion that didn't answer. So I usually take not answering as meaning not sure or probably not, and maybe not wanting to answer. So not to worry at all. This module will help you start to explore how to integrate this into your care philosophy and help you to think about how you and your center want to define your practices going forward. So next slide, please. Well, some of what we're presenting today and are using to develop the end-of-life care module is based on current research and regulations about care transitions specific to the skilled nursing center. Not just our experience from a hospice perspective comes from relationships of success that we've built with local centers in our communities. And our module will focus on one particular relationship that we've developed with one of our local care centers. Through the module, we not only aim to help you think about collaborations with local hospice organizations as one strategy for improving end-of-life care at your center, but we're also hoping that it'll help you to think about what end-of-life care at your center really means.
through these three objectives. So identifying, clarifying, and defining your nursing center's values related to palliative and end-of-life care, developing strategies and plans based on best practices for integrating your palliative and end-of-life care values into your nursing center's culture, and implementing your plan in collaboration with local hospice organizations to support your values and optimize quality end-of-life care. So today, what I'm hoping to do is to highlight some of the reasons why it's important to integrate end-of-life care values into your center's culture, and focusing on three basic premises. The next slide, please. So the first premise that we come up with is that good end-of-life care reduces hospitalizations, and I know that from some of the other speakers on today's webinar, it seems like that's a theme that is coming down the pike for this industry. And from a regulatory perspective, a recent report from the OIG and the Department of Health and Human Services that you might be familiar with recommends that skilled nursing centers be more closely monitored by the federal government when it comes to how frequently they send patients back to the hospital. Not only has the OIG recommended this closer monitoring, but they even have gone as far to recommend that CMS develop a quality measure to track and publicly report nursing center hospitalization rates, and to have it become a part of these surveys as part of the survey and certification process. The American Healthcare Organization has seconded this and is actually supporting linking Medicare payments to skilled nursing centers based on hospital readmission rates. So what we start to see here is that as an industry, reducing hospitalization rates is going to be something that care centers will want to be focusing on in the future. Also, I do think it's fair to say that for most of us, we got into the field of caring for people because we like caring for people, not because we wanted to comply with regulations. And while regulations are certainly one thing that we need to guide us in the way we develop our best practices, we also need them to be based on what is good care for the people that we're actually caring for. So studies tell us that frequent trips to the hospital not only adversely affect seniors' quality of life, but also put them at greater risk for complications and infections. And the American Healthcare Association came to the same conclusion and is already acting on this issue. They wrote to Congress earlier this year in support of measuring and publicly reporting hospitalization rates among skilled nursing centers when they were asked to comment on how to reform Medicare post-acute care payments. So all of these things, again, coupled together with the fact that the OIG's reports demonstrate these trips to the hospitals are costly to the system, we start to see the real value in reducing hospitalization rates across the board, and how if good end-of-life care can help with this, it also becomes of value to the care center. And when we talk about good end-of-life care as a means of reducing hospitalizations, I like to clarify hospice versus palliative care. So it's important, those terms are both terms that are frequently included in end-of-life care discussions, and it's important to know that while all hospice care is by nature palliative, not all palliative care is hospice, and there's that important distinction where hospice care has the specific criteria of the person who's receiving that care to have a prognosis of 6 months or less, and to no longer just be receiving curative treatment, whereas palliative care does not have those two restrictions. There are some separate studies that have shown that palliative home care is not hospice may also offer benefits to the healthcare system by allowing people to remain at home or in a home-like setting, so like a care center, and that helps them thereby avoid 30-day hospitalizations. So while I'll be focusing a little bit more on hospice care today, there are implications for palliative care as well that is not hospice. Next slide. So the second premise that we came up with is that what is good for the resident is good for the center. So I think we can all agree that word of mouth is hugely important, and I can't tell you how often people are shocked when I'm talking to them and shocked to hear that marketing could be important for a hospice. It seems sort of like an oxymoron, a lot of people think. But as we all know, our industry's caring has become quite a competitive one, and skilled nursing centers, to my knowledge, are no exception to that. If we can assume in the future that nursing center rehospitalization rates will be public, it's important to be aware of the implication those rates will have in terms of professionals who are prospective referrers, community members who are prospective residents, and family members who are will be involved because of their loved ones. You need to be aware of how the public will evaluate you as a center and weigh your care against other options. So by participating in this end-of-life care module, you'll have the opportunity to position yourself and your center as a pioneer and by developing and exemplifying best practices. Experience shows us at Good Shepherd that people are becoming more invested in the providers they're choosing themselves and for their loved ones. As palliative and end-of-life care becomes something that will be of importance to them and their continuum of care, it's our belief that ensuring your center is ahead of the curve on this will be extremely important going forward. And of course, coming from the hospice perspective, I'm here today to demonstrate some of the ways that hospice can help you with this. Next slide. So our third and final premise today is good end-of-life care is good care, period. The National Hospice and Palliative Care Association confirms that when hospice care is delivered in a skilled nursing center, residents experience enhanced pain management and families are increasingly satisfied with the end-of-life care their loved ones have received. And I will tell a story a little bit about that later on this morning. In fact, studies have shown that when hospice care is provided in skilled nursing centers, even the non-hospice residents in that center have better experiences. And I think we all know that family members who experience and witness the last days, hours, and minutes of their loved one's death will experience any death in their own way. And they remember that death. What we know is that they remember that death for as long as they live. So together, we feel that nursing center staff and hospice staff have an opportunity to make this time sacred for not only the dying resident or the person that you're caring for, but for his or her family and loved ones. In our experience, family may often see hospice as an extension of care provided by the nursing center. So if the family has a positive experience with hospice in the center, that experience in combination with the overall experience of care at the center all resonate as one positive experience that can reflect positively on the care center. So one of the main reasons we're here today is to talk about care transitions and the reduction of hospitalizations. It's of note to reiterate the implications of hospice care not only for hospice-enrolled residents, but for non-hospice enrolled residents. Studies have shown that when there's a strong hospice presence in skilled nursing centers, it reduces hospitalization risk for both hospice-enrolled residents and non-hospice enrolled residents. So in addition to providing better care experiences for all residents, it also helps to reduce those hospitalization rates. And while we're primarily talking about care transitions in terms of hospitalizations and dehospitalizations today, I do want to point out that another care transition that we're is very common and that we see all the time is patients coming home from a hospital or another setting to a skilled nursing center for the first time. And often the referring entity is setting up care not only for care in the center, but also making a referral to hospice care. So again, being ahead of the curve in terms of your center's best practices for end-of-life care can put you in a better position to receive these prospective residents. Next slide. So from a programmatic perspective, palliative care remains a fluid concept, allowing for a good deal of creativity and customization to fit the needs of a variety of settings. Our goal for your participation in the module is to assist you in developing and evaluating a center-wide palliative care program to meet the specific needs of your center. The module will also help you evaluate and improve your center's relationships with hospice providers and to think about strategies for optimizing these relationships. We feel that a primary hospice provider or providers should be an asset to your center and to your staff as you work to provide quality end-of-life care to your residents. So it's important when you're developing these relationships to think about what's important to you in a hospice provider, what are the values and missions that they have that might be similar to your own. Some other things to think about are what kind of caseloads do their staff carry, what is their response time, what complementary programs that they might have that might be a benefit to your residents to help in developing that person-centered care that we were talking about earlier this morning. And lastly, we want to acknowledge that there are many reimbursement-related difficulties that can complicate the provision of hospice care in nursing centers for patients who also qualify for SNF Med-A benefits. So in the module, we'll clarify and discuss some of the reimbursement mechanisms that can either promote or detract from quality end-of-life care. Next slide. So I talked a little bit about this morning that our module will focus on one particular relationship of success that we developed with a nursing center in our community, Marist Hill in Waltham. And when we first met, I remember it was several years ago, we met with the administrator there, and she told us, she was sick of hospices, knocking down our door, and marketers kind of coming in and, saying they wanted to work with her, and, she felt like there was a lot of false promises, and what she was really looking for in a hospice was someone to come in, care well for their residents, work well with her staff, and an organization that was connected by mission and values, which is a little what I just talked about. So we did have some similar values, and so she was willing to give us a try. We were both kind of community-based, nonprofit organizations. And so we started to develop a relationship. She said she would give us a try. We developed some staff training programs over there at Marist Hill to help build her staff comfort with end of life and their skills, how to recognize some signs of symptoms for when residents were starting to decline and becoming eligible for hospice. And they do that training annually now, and we send staff over there to kind of meet with them and do a refresher course with them as well, and at orientation. We also assigned a primary care team to that care center. So we assigned a primary nurse, social worker, spiritual care worker, volunteer, and aides that would work in that center. And it really worked in terms of helping our staff develop relationships and connections with their staff. They started to really see each other as extensions of care, not kind of competing or feeling like, in our experience, sometimes when we, care facilities will say to us, well, hospice comes in and they don't even talk to us. Like, they think that they're better, that they're providing care that we can't provide. And so we really worked to develop relationships where we felt like we were caring collaboratively, not just kind of competing against each other. And it really started to work. And so, in terms of talking about how residents, they can improve resident and family experiences, I'd like to finish with a story of success. I want to tell you about Jane and Arthur, I'll call them. So Arthur was 57 and Jane was 52 when Arthur first started showing signs, and he was eventually diagnosed with frontal temporal dementia. As Arthur's health declined over time, Jane had really tried to keep him at home, and she quit her job, and she was staying home and caring for him, and had him in adult-based health programs, and eventually it just was becoming problematic for her. She really felt like she was losing all aspects of her life. It just became too difficult for her to do it on her own, and when I spoke to her, I quote her, she said she was captured in a daily state of anxiety. So she eventually decided to move her husband and to be cared for at Marist Hill. When, Marist Hill staff started to notice that he had declined a little bit further, that he might be eligible for hospice, they called us in, and together we cared for him until he died last year. And I had the opportunity to speak to Jane shortly before Arthur's death, and she told me, I got my life back, and she didn't mean that in a way of saying that she still wasn't grieving or missing having a part of her daily, part of her daily life. But what she was describing really was the feeling of being comforted by knowing that the nursing center and the shepherd together were caring for her husband, and that she could always get a good answer about how he was or what was happening that day because of the close communication and collaboration between the hospice and the care center. And so for us, this was kind of one of those perfect examples of the sort of synergy between hospice and a care center working together to create positive experiences for their residents and families. And so with that, I just want to thank you all for your continued commitment to quality care and urge you to participate in the End of Life module that will be available later this August. Thank you.
Thank you, Jennifer, for that wonderful story and also that great information about why this learning module is so important. It is clear that your facility's implementation of quality end-of-life care has an impact in many areas. Your patient and family quality of life and satisfaction with care, your readmission rates, and thus your upcoming value-based payment opportunities, as well as your referral relationships. As Jennifer mentioned, we expect that our learning module will be available for you to access on our website by late August. As with all of our learning modules, it will be there 24/7 for you to access when convenient for you. But remember, the goal is for you to take this information, spread the learning throughout your center, and then implement in a way that will allow you to sustain. We will give you concrete tips and ideas in the module, and we need you to be the agent of change in your nursing center and with your hospice providers. Melissa?
Great. Thank you, Jennifer and Sarah. That was a great presentation. At this time, I just wanted to open up the lines for any questions. Nancy, can you tell our participants how to get in the queue to ask a question?
Sure, absolutely. If you have a question, please press *6 on your phone to unmute your line.
Nelia, are there any questions in the queue?
So far, none.
Okay. Okay, hearing no questions, we're going to move on to wrap up today's session. I just wanted to highlight the recommended next steps that your QI team could take between now and September. We want to ensure that your quality teams are identified, and you can actually use the Series 1 guide to help get your team started. That's on our website, www.healthcarefornewengland.org. We also want to review the learning modules that are available. They're in front of you on this screen. We have our pre-work module that's available now. Modules 1, 2, and 4, and 5 are available. Modules 3, 6, and 7 are coming soon within the next month. Remember, this is your QI process, and you can customize it to meet your needs. The value of the collaborative is that you're embarking on quality improvement along with over 500 other facilities in New England. And as we go, there'll be more and more opportunities to hear from you in order to learn from each other. So tell us what's working well in your place. And if you have a resident story, we'd love to hear it too. And I'd like to close by saying contact your state lead for more information on how to share or for more information about how to participate in this work. Please take a few moments to complete the webinar evaluation. Your feedback will help us improve these sessions and provide you with more meaningful programs. And also, today's presentation will be posted on our website, and the recording of this webinar will be available within a few days, so please share it with your staff. And thank you again for attending today. Have a great day, everyone.